Dr. Devaprasad, good evening.
Good evening.
Hi, hi.
I'm fine, thank you.
Good evening, all the doctors present here and all the aspirants. Well, we are going to start our class now. The topic is case-based discussion on acute subarachnoid hemorrhage, where the speaker is Dr. Dedeepiya Devaprasad, who is a lead consultant in Apollo Cancer Institute, Chennai. We have case presenter who is Dr. VALLURU SINDHU, who is DNB Emergency Medicine ID CCM Registrar in Apollo Cancer Institute, Chennai. We have moderator Dr. RESHU GUPTA, who is senior consultant and HOD in critical care medicine, Health City Hospital, Guwahati. We have moderator Dr. BANAMBER, who is a HOD critical care medicine, some ultimate Medicare in Bhubaneswar. Dr. Devaprasad ji, please you can take on the class.
Thank you, Farz Academy and all the moderators for inviting us here. This would be taken by Dr. Sindhu Vallari, who works in our unit, and she will lead the case-based discussion. We would interrupt intermittently with some questions if necessary to understand some aspects, and we'll encourage all of you to question her so that at the end of it, we'll all be clear with the topic that we are discussing today. Dr. Sindhu, can you please start your presentation, please?
So I'll be welcoming all the today's esteemed moderator, BANAMBER sir and Dr. Devapriya. So whoever have any questions, please, I request them all of them to put in the chat box. And I think BANAMBER sir will be the esteemed moderator today. So sir will answer a few questions, of course, with Dr. Devaprasad. And now we'll start. Thank you very much.
Good evening, everyone. So I'm going to discuss about a case today. Can you see my screen, sir?
Yes, screen is very much visible. Thank you. Your
Thank you,
voice
sir.
is clear.
Yes, thank you. This is about a patient we received. She's a 62-year-old female. She's a known patient, a known case of diabetes, hypertension, and hypothyroidism, and she's on regular medications for that. She was brought to the hospital with the complaints of sudden onset, involuntary movements of all the four limbs, which lasted for around 2 minutes, and again associated with the urinary incontinence. On arrival to the hospital, she's conscious but a bit confused, and her vitals wise, she's maintaining the saturation on the room air. Her BP was fine, 110/70, and her blood glucose is fine, 156 mg per deciliter. She's afebrile, and examination wise, there are no oral secretions, no evidence of any tongue bite. Neurological examination wise, her GCS is E4 V4 M6, just confused, and over a few minutes, around within an hour, her GCS came to be 15/15. Pupils were bilaterally equally reacting to the light, and no evident focal neurological deficit.
Dr. Sindhu, what are your differential diagnoses at this point?
Yes, sir. Since her GCS gradually rapidly improved, we're thinking of any new onset seizures, any stroke at this age, or hemorrhage in the brain. It could be any metabolic causes, toxins or drug-induced seizures, and finally could be a trauma.
Okay, when you're talking about metabolic causes, what metabolic causes are you considering?
Yes, she was a diabetic, her blood glucose is fine. Could be that any dyselectrolytemia can cause this seizures. So hyponatremia.
Okay, so you're talking about hypoglycemia induced seizures. Does hyperglycemia also induce seizures?
Yes, can happen, but sugars are fine. Yes, sir, can happen.
Can happen. So you're talking about this electrolytemia. Which electrolytes are you really concerned about?
Sodium, sir.
Sodium. Can calcium calcium also cause seizures?
Yes, sir. Hypocalcemia can cause. Yes, sir.
Okay, hypercalcemia also in extremes can cause seizures. Okay, so you're talking about stroke and hemorrhage as well, toxins and trauma.
Yes,
Okay,
sir. Yes, sir.
so what will be your immediate plan of care for this patient?
Yes, sir. Immediately, so general thing initially, if there is any, it's always ABCD. So we'll stabilize the patient first. So if there is any, for this patient, she's maintaining the airway and BP is fine. If not, we need to first secure the airway, and BP and GCS continuous monitoring should be there. And as I already said, we need to see how our electrolytes are, whether there any source of any infection, everything we need to send for the samples. And then for specific management, so since she presented with seizures, we need to load her with an anti-epileptic agent. So in this case, we loaded her with levetiracetam. And then if they are having any pain, we can load with analgesics. And then immediately we have to go for non-contrast CT brain scan.
Okay, what makes you
So
think? What makes you think the airway is patent?
Her GCS rapidly improved. She's 15 by 15, maintaining the airway in room. Saturation is normal in room air, sir.
So, so you were able to speak to her. She was able to speak to you.
Yes, yes, sir. Yes, sir. Yes, sir.
So that's one way. And then you're also looking at GCS. You said you're looking at CBC, electrolytes, urea creatinine, etc., anti-epileptic agents, and you said you gave her levetiracetam. How much levetiracetam did you
Yes.
give?
For her, 1.5 grams were given, sir.
1.5 grams stat. Okay, why did you not consider giving lorazepam at this point of time?
She's not actively seizing, sir.
Okay, so she's not in a patient. So when do you consider to give lorazepam?
When the patient is actively seizing, that would be the drug of choice, initial first drug of choice.
Okay, so okay. Uh, now, suppose this patient had not regained a consciousness, and
Okay,
then
sir.
she had presented with seizures. Then what would be your thought?
So we need to think of any non-convulsive seizures also should be kept in mind, or it could be a post-ictal confusion, post-ictal state also, but non-convulsive seizures should be kept in mind.
Okay. Just to specifically say, if a patient does not regain consciousness in 5 minutes, yeah, it could be a prolonged post-ictal, but always rule out non-convulsive status in these patients and treat them as if they have non-convulsive status. That's the point. Okay, please proceed. You've asked for a non-contrast CT.
Yes.
Any particular specific thing that you would ask your radiologist to look at, or you would also look at?
Yes. For her, we need to think of a stroke. It could be either ischemic or hemorrhagic. So we need to look for any hemorrhages or a infarct or
Okay.
any specific lesions.
Okay, considering especially she's got a seizure. Okay, okay then. Okay, please proceed.
Yes. So this is the CT of the patient. As you can see, she's having some bleed in the midline bifrontally, more to the right side, and there is some bleeding in the right temporal region. Uh, I have a few specific cuts. As you can see, there is a mid-frontal bleed, and then right temporal region, there's a small bleed. So this patient was, and then patient was taken for DSA, which showed there is a small left ACOM saccular aneurysm. So she's having a smile SAH and mid-frontal that is around size of 12 by 4 millimeter size.
Dr. Sindhu, at this point of time, your
Yes, sir.
initial thoughts were that it was infarct or a hemorrhage.
Yes, sir.
Okay. Did you even consider subarachnoid hemorrhage in your differential at that point of time?
Yes, she presented with two things. One is post seizure, there is a transient loss of consciousness, and her age is more than 40. So there is a rule called Ottawa SAH rule. So based any criteria based on that, we have to consider SAH also in these kind of patients.
Okay. But what is the commonest presentation that
Yeah.
makes you consider that this could be aneurysmal subarachnoid hemorrhage?
This patient didn't typically present, sir, but usually subarachnoid hemorrhage patients will present with sudden onset headache, and the headache will reach the maximum intensity usually within an hour. So that's the most common presentation. And when they present to the hospital, we can use a rule called Ottawa subarachnoid hemorrhage rule. If
Okay.
the patient is having any one criteria, we can further investigate for subarachnoid hemorrhage. So age more than 40 years, any neck pain or stiffness, sudden onset, and any loss of consciousness, and sudden onset of this pain during any physical exertion, and the kind of headache like sudden thunderclap and instantly peaking in intensity, and any the nuchal rigidity, any limited flexion on examination. So we need to further think of subarachnoid hemorrhage. So this patient has age more than 40 years, and she's a female, and there is also transient loss of consciousness.
Okay. Now let me take you on a different tangent. This patient, because you did a CT, you have a subarachnoid hemorrhage evidence there, and therefore you did go with the DSA. Let me put it on the other side. Suppose you had a patient who had a headache, and you considered an aneurysm as a possibility, but
Yes.
then you find that this particular patient had a normal CT when you do it.
Yes.
Then how do you think you will proceed? Will you still think it's subarachnoid hemorrhage?
Yes, we can still investigate. So we can, if we were still thinking of subarachnoid hemorrhage, we can, and if the patient is having any neurological deficit, we can go for a lumbar puncture and to look for any xanthochromia. So if the patient is having any xanthochromia on that, we can go for again a CT angiography or DSA, and then determine any presence of aneurysm.
Okay. Details, can you zoom and sorry, press in a greater detail this one?
Uh,
Hello?
Sorry, sir, shall I proceed?
Yeah. Do you can you explain this in greater detail?
Yes, sir. So if the patient presents with headache, severe onset, sudden onset headache, and the patient presents less than 6 hours, we can straight away go ahead for CT. And if it shows a subarachnoid hemorrhage, we can treat that accordingly. If the patient is more than 6 hours and with or without any neurological deficit, and we did CT, but there is no evidence of subarachnoid hemorrhage, we can go ahead with the lumbar puncture to look for any xanthochromia that shows the presence of blood. So if the if patient is positive for xanthochromia, then we can still go ahead with the CT angiography or and DSA to look for the aneurysms.
Okay. How will you differentiate from a lumbar puncture between a subarachnoid hemorrhage and a traumatic tap? What will happen if you have a traumatic tap, and what will happen when you have a subarachnoid hemorrhage? When you have a traumatic tap and you serially collect, will do you think the intensity of the blood in each of the fluids will go down? It would, no? In a patient with subarachnoid hemorrhage, serially, it will all remain the same, right? So that's how you would differentiate between subarachnoid hemorrhage versus a traumatic tap. Okay. So this particular patient presented with the seizures. Hello. So this particular patient presented with the seizures and hello, Dr. Sindhu. Okay, this patient presented with seizures So your initial diagnosis was whether it was a seizure that was due to any other cause. So you did a CT, and the CT did rule out ischemic stroke or a hemorrhagic stroke, and then you were able to make the diagnosis of subarachnoid hemorrhage. This was not considered very common in this particular patient because this patient did not have the classical presentation that you'll usually account with, namely thunderclap headache or onset of headache during exertion, no neck stiffness that this patient reported. But nevertheless, in any patient who's got uh, loss of consciousness and above 40 years, you would consider subarachnoid in the differential, which is what is there. And of course, patient also highlighted the fact that in a patient with subarachnoid hemorrhage, you may have a normal CT very rarely. In that instance, if you're still thinking that it is subarachnoid hemorrhage, you would go ahead and do a guarded lumbar puncture. And when you do a guarded lumbar puncture and you see blood, the question arises whether this is a traumatic tap or a subarachnoid hemorrhage. Here you can understand that when you collect the sample serially in a traumatic tap, the intensity of blood will come down slowly. But in a patient with aneurysmal subarachnoid hemorrhage, it will continue to be bloody in all the serial samples. Yes, Dr. Sindhu, please continue.
Sorry, sir.
I think
Wi-Fi got disconnected.
yeah, I understand. There's a lot of rain here. Even my Wi-Fi is unstable, so I understand that. Please continue.
Sure. Yes, sir. So we can look for xanthochromia, and if it is positive, we can go ahead with the CT angio to look for the aneurysms. Yes, sir. So if the patient is indeed having,
sorry,
yes, sir. Tell me, sir.
Please tell me. Please tell me. In this patient, based on now you have a diagnosis of subarachnoid hemorrhage based on the CT. So here, specifically when you talk about subarachnoid hemorrhage, how would you like to approach your patient? Because you did talk about a specific management. You said that you'll have a general management where we'll address the A, B, C, D, and then specifically you will address the problem. Of course, you did treat the seizure with a loading dose of levetiracetam. And you did think that this patient had no non-convulsive status because her GCS had returned to normal. You had a CT done, and the CT suggested aneurysmal subarachnoid hemorrhage. So when you are talking about aneurysmal subarachnoid hemorrhage, how would you really approach this particular patient from here on?
Initially, we can actually categorize the patients based on the severity of the SAH. There are a few classifications here. So based on the patient clinical examination, and it can be based on the radiological examination of the patient. So based on clinical examination, to predict the mortality of the patients, we can have two classifications: Hunt and Hess and World Federation for Neurological Societies. So there are 5 grades in both the grading systems. So first 3 grades will carry a good prognosis, and we can go for the immediate treatment. The 4th and 5th grade, they carry very poor prognosis, carrying even 80 to 90% mortality in those patients. So first grade, sorry, sir.
Okay. Which grade do you use, the Hunt and Hess or the WFNS?
We usually use Hunt and Hess.
Okay. But yeah, you could use, but I think the WFNS is now more universally accepted. So can you tell us a bit about both these gradings?
Yes, sir. So first grade patient will usually be asymptomatic, or they can present with very minute headache, and the GCS will be 15/15 without any neurological deficit. So the second grade, they'll have a GCS of 13 to 14, and but without any neurological deficit, and they can have moderate to severe headache and some nuchal rigidity. Third grade, again, GCS of 13 to 14, but they'll have some focal neurological deficit, and they can be a bit confused. And fourth grade is GCS anywhere from 7 to 12 with or without any neurological deficit, but the patient will have severe severe hemiparesis, and the patient can present with stupor. Uh, Grade 5, anything less than GCS less than or equal to 6, and the patient will have extensive posturing, and patient will be in coma, and they carry a huge mortality and morbidity.
Okay. Now, this patient of yours, which grading
Yes,
system will you use in the Hunt and Hess and
yes,
WFNS? And before that, I just thought very well done, but I'm just going to reiterate the Hunt and Hess and WFNS separately for the benefit of whoever is attending. In Hunt and
yes.
Hess, which was the previous one, if you are asymptomatic or if you have just mild headache, it's grade 1. If you have more headache and you have only cranial nerve palsies, it's grade 2. Anyone who's got a neurological deficit, it becomes either 3, 4, and 5, depending on the severity of the neurological deficit. In addition, if you have confusion or lethargy, it's grade 3. If you are more drowsy, it's grade 4. And if you are in coma, it's grade 5. Likewise, because the Hunt and Hess grading can lead to ambiguity, and therefore, because GCS is something that is more objective, the WFNS is now used. So if you have a GCS of full without any focal deficit, without any hemiparesis, it is grade 1. If you have a mild drop in GCS, that is 13 to 14, depending on whether you have hemiparesis or not having hemiparesis, you will have grade 2 or grade 3. If you have a GCS between 7 to 12, that's grade 4. And if you have a GCS between 6 to 3, it's grade 5. So based on this is the WFNS, and WFNS is more commonly used nowadays. Now, your patient, which grading system does this patient fall into?
This patient is have grade 1, sir. So if we use Hunt and Hess, initially it could have been grade 2, because she presented with confusion, but after that she
Grade
rapidly
3.
improves the GCS 15 by 15. So grade 1 in both the systems.
Okay, this is usually when this particular patient presents to you, that's when you grade them. So
Yes,
this was so that's where she is. So based on that, what is the mortality of this particular patient? Estimated mortality
yes.
based on that?
Estimated mortality is 30%, sir.
Okay, I think if it's
Grade
just
one
grade
is
1,
grade
it's
one
going
is yes,
much
sir.
lesser, 5 to 10% maybe. Okay, okay. And you also did a CT. Do you have a CT
Yes,
grading system that you use?
yes. Yes, sir. So, based on CT grading, we can use modified Fisher scale, sir. It has four grades. So, first one is thin SAH, that is less than 1 mm thickness, and it won't have any, those patients won't have any intraventricular hemorrhage. So, grade 2 is again thin SAH, but with the presence of intraventricular hemorrhage. And grade 3 is thick SAH, that is more than 1 mm thickness of the bleed, but without intraventricular hemorrhage. And grade 4 is thick SAH with intraventricular hemorrhage.
Okay.
So this
So
patient is
thin
yes, sir.
intraventricular hemorrhage with and without IVH is 1 and 2. Thick
Yes,
SAH that is more than 1 millimeter in size with or without IVH will be 3 and 4. That's what it is, right? So in
yes,
your patient,
yes.
what will be your grading?
So this patient is having a hemorrhage of thickness at 12 mm by 4 mm size. So she will come for, no intraventricular hemorrhage in the initial CT. So grade 3 modified Fisher grading.
Okay, so it is more than 1 millimeter in size, so it's grade 3. And
3.
you talked about the Hunt and Hess and WFNS used as a predictor of mortality. So,
Yes.
what is the usefulness of grading somebody? Why take the trouble of grading them using this Fisher or the modified Fisher scale? What additional information do you get?
So this can predict with what percentage the patient can land up in vasospasm and further complications of delayed cerebral ischemia, cerebral infarctions.
Okay, okay, please continue. Okay,
Yes.
so now you've had this particular patient you've classified.
Yes.
So your patient you says has grade 1 to 2, the Hentran and the modified Fisher. Okay, so from now
Yes.
on, what you've been able to make a diagnosis, you've been able to classify your patient. So what would be the
Yes.
specific management that you would give your patient at this point of time? I want you to be specific about all points that you would consider in the specific management of this patient.
Yes, sir. So initially, medical management wise, we need to have a strict BP control. This is a level 1 recommendation. The BP should be less than 180 mm of mercury, and the MAP should be maintained. MAP should be maintained above 80 and should be treated if the MAP is less than 80. And the rebleeding chances for these patients, even if you treat, would be high, very high if the BP is more than 160. So tight BP control is the first thing we need to do, and the specific management would go for intervention by prompt obliteration of that ruptured aneurysm.
Okay.
Uh,
May I ask you, if this particular patient had a blood pressure of 170 on presentation, would you would
okay.
you would you go and
I will.
reduce the blood
I
pressure?
won't treat it. I won't treat it immediately, sir.
Okay. So whereas if this patient had a blood pressure of say 200, would you treat it?
Yes, sir. We should treat it. It should be below at least 180 mm of mercury.
Okay. And maybe 180, but yes, that's right. That's the recommendation. But you understand that it gets reduced to much lesser in most of the other units. But definitely don't
Yes.
allow it to go to less than 160. I'm very happy
Less
if
than
you
160.
keep it around. I'm very happy if you keep it around 180. Yeah, that's right. Okay.
Yes.
Okay then.
And even
Please continue.
sorry, sir.
No, no. I think there's somebody else in the background. Please continue.
So even more so important is we need to avoid wide fluctuations in the BP. So we need to maintain a equal level of BP. So a better way of investigation, we can place an arterial line and maintain the blood pressure. If we need to treat the blood pressure, IV antihypertensives would be of choice, drug of choice. So a few
Such as
other things
such
we need
as
to remember.
IV and antihypertensive such as.
Nimodipine, sir. Nimodipine
Okay.
infusion can be started. So this can prevent further complications of the subarachnoid hemorrhage like vasospasm and delayed ischemia.
Do you think IV nimodipine is such a powerful antihypertensive? Suppose this patient's blood pressure was say 220 and you wanted to keep it at 180. Do you think it will be able to achieve it?
Calcium channel blockade and even calcium channel blockade can be done, sir. Even
That's the any IV nimodipine. Would you consider IV labetalol in these patients? Yes, I agree that you will use a
yes,
titrable
yes,
IV drug. So any IV
yes,
titrable IV drug,
yes, sir.
IV
Yes,
IV
yes.
labetalol. Okay then. Yes. So
Few other
IV
things.
labetalol and IV nicardipine are the ones that are usually preferred. But since
Yes,
you're already probably using nimodipine, you probably won't want another calcium channel blocker. So
calcium
you
channel.
could probably use IV IV labetalol. Yeah, please continue.
Labetalol, yes.
Continue.
Yes. So few people would consider tranexamic acid the early antifibrillary therapy, but that is not really recommended. There is no backup evidence for that. And also, if the patients are already on any anticoagulant, emergency reversal of this anticoagulants is recommended. There are few studies where transfusing platelets in those patients who are on antiplatelet drugs, but there is no proper evidence to support it would help in those patients. Coming to the specific surgical intervention, as I already said, it's complete obliteration of the prompt obliteration of this aneurysm as soon as possible would be the choice of treatment. If complete obliteration is not possible, then partial treatment obliteration, and again with delayed retreatment within 1 to 2 months needs to be done. So obliteration is achieved by either coiling, usually by either coiling or clipping. Uh, each coiling and clipping can have their own advantages and disadvantages. So coiling is basically used for any internal carotid aneurysms and posterior circulation mostly, uh, uh, and also in anterior circulation aneurysms who are of good grade, that is 1, 2 to 3. Clipping is basically used for patients less than 40 years age because they'll have higher durability, and it is used in MCA aneurysms. But the cons of this coiling and clipping is the coiling can have higher risk of rebleeding compared to clipping, and clippings can have higher risk of seizures. And also, coiling is basically used for wide necked aneurysms, and for fusiform aneurysms, flow diverters are used. But any this obliteration, the surgical intervention, that needs to be done as early as possible, and not beyond 4 days, because as the vasospasm and ischemia will set in, we need to intervene before that.
Okay, I think we should need to spend time on this particular slide for others also to understand and comment on it. Maybe
Yes.
may I just ask you two questions? What would
Yes.
be the preferable if you have multiple aneurysms? Of course, one of those aneurysms would have bled, but when you
Yes.
do a DSA, you see multiple other aneurysms. Then do you think they should coil or clip?
Uh, Sorry, sir. Then
Yeah, generally, when you have multiple
um,
aneurysms, they would want to
clip.
coil them.
Sorry.
I mean, sorry, not coil them, clip them. You're right. And if you have very distal aneurysms, what will you do?
Distal clipping. Hello.
Okay. Okay, continue. Continue, please.
Yes, sir. Wide based, we cannot clip them. We need to since the aneurysm will be having a very wide base, we cannot clipping cannot be effective. So those kind of patients will have to be coiling has to be done in those patients.
Okay, next slide, please. Yeah.
This particular patient has sacral aneurysm, and this patient had underwent a novel treatment. So since she's having left ACOM aneurysm, she underwent left supra. There was an incision given under the left eyebrow that approached through the left supraorbital. Mini craniotomy was done, and the clipping of this left ACOM aneurysm was done under general anesthesia. So post surgery, she didn't have any complications. She was on nimodipine infusion for a few days. There are no neurological deficit. She was fine, and she was discharged in a stable condition. Particular patient.
Okay, so this particular patient was uneventful. I think this particular patient probably you could have even coiled, but I think here the surgeon decided to clip.
So
And
this
of course, the clipping was
treatment, initial
uneventful.
treatment, and
Yes.
we need to.
And what are the particular medical complications that you'll actually uh, try to follow up and avoid and actively treat in the ICU in these patients?
Yes, so these particular medical complications can be divided into early complications and delayed complications. So early complications, so this particular patient is stable all throughout, but if they're present with low GCS or any compromised airway, low hypertension and all, so we need to first initially resuscitate the patient. That comes first, and then we need to prevent any rebleeding. So rebleeding, as you already discussed, early obliteration of the aneurysm is needs to be done, but still there can be chance of early rebleeding, which chances are more high in the first 24 to 48 hours. And if the patient develops any hydrocephalus, it usually within first 2 to 3 days, usually 72 hours. Hydrocephalus can be treated by any EVD or lumbar drainage. But there is a chance EVD can increase the chances of rebleeding in these patients. So, and then raised ICP, patients who are having a raised ICP needs to be treated with 3% saline, head position, neutral head positioning, head and elevation, and again lumbar drainage. And those who present with the seizures, the anti-epileptics are usually recommended first at least for a week. and especially those patients who are having cerebral infarctions or MCA aneurysms, on a patient who is having hydrocephalus, they need to be on anti-seizure prophylactic medications. Usually, Levipil is the drug of choice, and fentanyl needs to be avoided as it increases the morbidity in these patients. Levetiracetam would be the choice of drug to prevent seizures. Those are the usually encountered early complications. And
Okay.
coming to
My,
late,
my, my, my question at this point of time would be
sorry,
so if you have a hydrocephalus, very
yes,
early hydrocephalus at presentation,
yes.
I know you want to acutely treat the hydrocephalus, but if you have a option of actually taking him and coiling and treating the hydrocephalus after coiling, or
Yes.
first doing EVD to drain it and then coil, which do you prefer and why?
Early obliteration would be the choice of treatment, should be the choice because if we put a EVD before coiling or clipping the patient, the chances of rebleed will be very high in those patients.
That's true. That's true. Okay. Suppose we arise in a situation where this patient is has got an acute hydrocephalus, and you need to make arrangements for the coiling and all of it. It's going to take time. But
Yes,
this patient is acutely deteriorating, and you think as you need a hydrocephal evacuation. Of course.
yes.
Then, what additional precaution will you take? That you will have to place the EVD first and then the coil. What additional precaution would you take?
Um,
Norm, Normally, when you do this, you will have to do it under
yes.
strict ICP monitoring. Uh, uh, uh,
ICP monitoring needs to be done.
that's the only condition where you will probably need an ICP monitoring in this case. When
Yes,
you're dealing with a hydrocephalus
yes,
without even addressing the aneurysm, then you don't want to decrease it by too much, because if you're
yes.
decreasing the ICP by too much, you're increasing the chances of rebleed. So these are some of the
Rebleed.
early
Yes,
complications. Can hydrocephalus
yes,
occur late? Yes, they can occur late as well.
yes,
Okay.
yes, yes.
Okay. Okay. Now go
Because
to
of
me. Go to the specific late complications of aneurysmal subarachnoid hemorrhage, please.
Yes, because of due to various mechanisms like cerebral microthrombosis, the vasospasm can happen, and vasospasm can lead to delayed cerebral ischemia and cerebral infarction. That is one most dreaded complication, late complications. I'll be talking about detail about the DCI a bit later. So other leg complications are sodium dysregulation that natriuresis can happen because of cerebral salt wasting or SIDH. So we need to treat that with 3% saline and maintaining the euvolemia. We should not dehydrate patients. Again, dehydration and hypovolemia can lead to vasospasm and ischemia. Systemic complications can happen, like if the patient can have cardiomyopathy because of this, and patient can have any sepsis, or because of the low oxygen and prolonged ventilation, they can land up in pneumonia, ARDS, or and even thromboembolism can happen as a late complication. Those conditions need to be treated. Coming to proning, if need be, we can indeed prone these patients with proper ICP monitoring in these kind of patients if need be in ARDS, and we need to maintain euthermia and euglycemia. Around 80 to 120 mg per deciliter should be the choice target of maintaining the glucose, and prolonged hospitalization can affect the nutrition also, though, so they should be it should be maintained properly. um, Coming to specific delayed cerebral ischemia, so it's there are various modalities which can detect vasospasm, spectroscopy, transcranial Doppler ultrasonography, or
Okay,
can be
okay.
used.
Dr. Sindhu, before you really proceed to delayed cerebral ischemia, I just want to understand from you, how will you clinically identify delayed cerebral ischemia? One would be the timeline that you're talking about.
Yes, yes.
Other than that, in that particular timeline, how would you say that this patient would could have delayed cerebral ischemia? What will you be actively clinically looking at the patient to think that this
Yes.
particular patient is developing a delayed cerebral ischemia?
Yes, so patient can have a drop in GCS. Any drop in GCS by more than or equal to 2 points, with or without any neurological deficit, that should prompt us to think on this direction, and it should at least last for at least an hour. And this drop in the GCS and neurological deficit should not be attributed to any other causes, and this should not be evident immediately after the surgical intervention in these patients. Then we should be thinking of a delayed cerebral ischemia.
Okay,
And it
please.
usually develops between 4 to 14 days, and it can maximum 20 21 days it can happen.
Okay, I think you've had a slide on it. Please go through the slide again. Not a problem.
Yes, sir.
So,
Yes. So we need to monitor the GCS and look for any focal neurological deficits, and it should not happen immediately after the surgical intervention. And this uh, alterations should not be attributed to any other causes. Then we need to think of cerebral ischemia.
okay. Uh, if you have a patient with delayed cerebral ischemia, or like that you suspect, like you said that between 4 to 14 days, if you have a drop in GCS, if you have a new focal neurological deficit, if you would have
Yes.
pupillary abnormalities, you would think in terms of a delayed cerebral ischemia in these patients. How would you really prevent these delayed cerebral ischemia? Do you have mechanisms to prevent them? What are your mechanisms or investigations that you have to identify them once they are there? And what are your mechanisms that you have to treat them? Your strategies.
Yes. We can identify it based on Doppler ultrasonography, and we in spectrography we can use MRI, and to prevent prophylactically, nemodipine is to be started as soon as possible. Usually it is 60 mg every fourth hourly. If the patient is able to take orally is fine. And to maintain euvolemia and tight BP control, it should not be MAP should be maintained above 80, so that there will be proper cerebral perfusion. And we can also go for angioplasty of the proximal vasculature, so that the distal perfusion will be better.
Can you please explain to me what you mean by tight BP control? It may just
Yes.
look.
So the MAP should be above 80 to 90 mm of mercury, and it should not the BP should not fall, especially should not fall below 140 mm of mercury. So the systolic
Okay.
BP.
Can you just tell us the difference between the blood pressure initially and now?
Yes, sir. So before coiling or clipping, before surgical intervention, if the BP is less than 180, we need not treat it. And if the MAP is more than 80, less than 80, we should treat to keep the MAP above 80 mm of mercury. But after treating, we can after treating after this one, BP can the surge BP should not the systolic BP should not have around 140 mm of mercury, sir.
No, no.
And
Can we just say that before treating the aneurysm, before the aneurysm has
yes,
been coiled or clipped, then your BP targets are just definitely keep it less than 180 if possible.
yes, sir.
But if the patient has had a repair of the aneurysm by either means, if by
Yes,
chance the blood pressure is higher and they have vasospasm, don't do anything to don't treat the blood pressure and try to bring it down actively, right?
yes, sir.
So
Yes,
that's
sir.
that's the idea. So if this particular patient now has a BP of 190, 195 for whatever reason, don't do anything to actually reduce the blood pressure, because you would be aggravating the delayed cerebral ischemia. That's what
Delay, sir.
they
HK,
mean.
vasospasm.
Okay, that is there. And remember that nimodipine is a prophylaxis, right? 60
Yes,
milligram
yes,
Q4 thaling. So it should be started as early as possible, definitely before 4 days, because after 4 days, the vasospasm
will set.
actually
Yes,
begins. So once there
yes,
is delayed cerebral ischemia, the only treatment, as you said, would be to ensure that there is at least before we talked about 3H, hyperolemia, hypertension,
Hypertension.
and uh, uh, hydration. But now we don't talk about hyperolemia. We just talk
Yes.
about two H's. We talk about
Euvolemia.
hydration, and hypertension. Okay, so that's
Yes.
where we are. So I'm happy
Yes.
that you said that you're going to make euvolemia, and of course angioplasty. Sometimes, if you have proximal vasculature, like if you have an ACOM aneurysm, sometimes the proximal vessels can also go in for spasm. Then yes, angioplasty. Yes. Okay. Okay. Please
Yes.
proceed.
Yes. Uh, so these patients can have a prolonged may need a prolonged therapy, so rehabilitation if they have any neurological or any support, and seizure management needs to be done, and these patients needs to be under a proper follow-up to look for any re-rupture of these aneurysms, or these patients are prone for developing any new aneurysms also. So they should be under follow-up, and long-term cognitive and mood management should also be under consideration for these patients.
Okay. While we are talking about delayed cerebral ischemia, you did tell that if you have delayed cerebral ischemia, you may do a CT scan to identify or an MRI to identify new infarcts. But
Yes,
do
sir.
you think there's anything that you have at the bedside that you can use to actually identify DCI
Transcranial
to
Doppler can
predict?
be transcranial
Can you tell me?
Doppler
Can
ultrasound
you
can be
can you
done.
tell me? Can you tell me how you're going to use that? Are you aware of any
And
particular
yes,
ratios or
that
measurements?
velocity, we can see the velocity of the cerebral blood flow. It should be more than 120 centimeters per second. And there's a ratio called Lindy-Card ratio that will see the velocity of the blood in the particular affected vessel compared to the as opposed to the internal carotid vessel. So the ratio should be more than 3, sir.
Okay. So you did talk about the Lindgren ratio. The advantage of TCD is it is repeatable at the bedside. So
Yes,
you
yes.
know that if you have a vasospasm and you do a strategy, whether it is better or not, you could repeatability is something that is very useful here. Can you go back to the previous slide that you put on the complications, late complications, late complications?
Yes.
Okay. You did talk about sodium dysregulation. What are the two causes of sodium dysregulation? What is it? Is it hypernatremia, hyponatremia? What is common and what causes them?
Hyponatremia, sir. One is cerebral salt wasting syndrome, and another could be SIADH, sir.
So, do you have any mechanisms of distinguishing between the two?
No, no, sir.
No.
Clinically,
Okay. Clinically, no. Lab wise, no. Definitely.
lab,
Lab
yes,
wise, you
lab,
cannot, because in both the serum sodium will be low, in both the urine
yes,
sodium will be high, in both the serum osmolality will be low, in
will
both
be
the urine
low.
osmolality
Yes,
will high.
yes,
Maybe you could use uric acid. Maybe sometimes
yes, yes.
it is definitely low in patients with SIDH. In patients with cerebral salt wasting, it could
Cerebral
be
salt,
high.
no,
It could be high, but if it's normal, it
usually
doesn't mean anything.
normal.
So there is only one clinical indicator of whether this patient has got cerebral salt wasting or SIDH, and what is that?
Mm.
Hydration.
Hydration.
Uh,
Yes. If a patient has got, if the patient is
cerebral wasting,
dehydrated, then more likely
cerebral
cerebral salt wasting.
cerebral wasting.
Okay. So what will be your treatment strategies for sodium dysregulation in these patients?
We can start with 3% saline infusion, and we need to maintain euvolemia in these patients. And
Uh,
sodium target should be around 140 milliequivalents per deciliter.
Okay, let me tell you that this particular patient has got a very low uric acid and maybe mild edema that makes you think that this mild peripheral edema, making you think that this patient is euvolemic to slightly high in volume. Would you recommend water restriction as a strategy in
No,
these patients with SIADH? Which is
no, sir.
you normally recommend water restriction, no fluid
Yes,
restriction
yes,
in this
yes, sir.
patient.
No, sir. We should not do that because we need to maintain the intravascular proper volume so that it won't cause vasospasm, and patient will land up in DCI, sir.
So this is one area of concern in these patients. Even if you are clinically treating them as SIDH, you would not advise fluid restriction. In fact, you would try to keep them slightly on the
Hydrated, yes.
hydrated side. Okay, you did talk about non-cardiogenic pulmonary edema, and you did say that you would treat them even with proning it's all okay. That's fine. Any other specific complications that you would have seen in the patients that you have treated?
Mm.
Okay.
Um,
Okay. Please continue.
yes.
Please continue. Please continue.
That's it, sir. Sorry.
Okay. Can you?
So to summarize, so patients coming with sudden onset headache with peaking intensity within an hour. So it should prompt us to investigate in the side of subarachnoid hemorrhage. So we can initially use Ottawa SAH rule. If the patient is satisfying any criteria in that, we can go ahead and investigate for a subarachnoid hemorrhage. If the patient even if the patient is didn't have any evidence of SAH in the CT, we can still go ahead do the lumbar puncture to look for xanthochromia, and then go for a CT angiography and DSA to look for aneurysms. And if the patient didn't indeed have a subarachnoid hemorrhage, so first the initial stabilization of the patient, and then we have to go for specific management, that is obliteration of the aneurysm as soon as possible. And and side by side, we need to maintain the maintain the target blood pressure, and maintain the map above 80. And then if need be, use and then prophylactic use of nimodipine to maintain the blood pressure, and then maintaining euthermia, glycemia, and to prevent further complications and further complications. Yes.
Thanks, Dr. Sindhu. I think you will have a lot of questions, and can we ask the others in the panel to also ask some questions to you? Thank you,
Yes.
Dr. Sindhu. That was nicely presented indeed.
Yes, I
Thank
have a
you.
question. Hello.
Yes,
Yeah,
sir.
please.
Yes. In case of post-operative rebleeding, we cannot
Yes.
do the daily CT scan. Hmm.
Okay, sir.
So nowadays, in some centers, we can do the optic nerve diameter sheath measurement by ocular ultrasonography.
Yes,
It
sir.
is very much helpful tool to monitor whether we continue the 3% sodium chloride or not. This is my
Yes, sir.
first. Another question is, in case of post-operative follow-up, whether it is with hydrocephalus or without grade 4 subarachnoid hemorrhage.
Okay.
You did explain about the triple phase. If the patient comes with raised ICP with posterior pituitary damage, then triple phase also will be present. In this management, in case of raised ICP, I think triple phase management can be included in this post-operative management. Thank you.
Yeah, I understand that a lot of ONSDs can be done because it is repeatable. It helps you to identify raised ICPs. I agree that it is done in most ICUs, but specifically as a recommendation, as a management tool for aneurysmal subarachnoid hemorrhage, it can't, because we still don't have data enough to say that it has an impactful course in the management. Yes, it is useful, but we need more data to say that it can be used as a tool in managing these patients.
Yeah, so good presentation, I'm Dr. So, yeah, you were talking about transcranial Doppler to assess the flow velocities, but there are other measures which can also help you to understand the cerebral perfusion. The target cerebral perfusion pressure is high, and that's why you have to target a mean arterial pressure of 90 to 110. So, brain tissue oxygen saturation is one entity which you can monitor. Okay, so there are several ways of monitoring blood tissue oxygen saturation in these patients. One can be a reverse jugular oximetry, where you place a central line in reverse direction and you monitor the SCVO2. which should be more than 70. And intracranial pressure measurements are also possible, but not, there are studies which have not shown much benefits in terms of morbidity and mortality. But yes, in selected cases where you have a severe bronchospasm and you need to really understand what's going on with the perfusion of the brain, so you can actually monitor intracranial pressure and you transduce it continuously. There are other monitors like you can place intracranial bolts and Lycox monitor can also be applied where you monitor brain tissue oxygen saturation. You can also go ahead with cerebral microdialysis where you monitor the CSF lactates. Okay, and the CSF lactate pyruvate ratio can also guide you about the brain tissue oxygen which is compromised. Because these transcranial Dopplers that we do, it may not give you fair assessment of vasospasm. Moreover, it has got subjective variability. So, if you have a comprehensive neurosciences, and you have patients with subarachnoid hemorrhage, especially aneurysmal bleeding, or coiling clipping is done, and you have a patient who is repeatedly deteriorating neurologically, and vasospasm is one of the concerns. You can go ahead with the monitoring. But I think the rest of the have been covered very good presentation. Anyone else would like to
I think we have some background noise.
Can you please to the audience? There is one question on the role of nimodipine. When can we start nimodipine? So, as far as possible, the nimodipine can be started as early as possible. Usually,
Hello, this is Dr. Ray. Am I audible?
Yes. Please
Yes.
speak on.
There are quite a few questions, but as I see, I scanned through all the questions. One question very high up early it was asked is that, Didi, you talked about difference between traumatic tap and subarachnoid hemorrhage. The question is that would you be very, very clear? Clarity is this, that as you said, that the traumatic tap actually slowly, I think gradually it becomes less and less and less. It gets cleared up.
Yes.
And the subarachnoid hemorrhage doesn't really give you that opportunity. It continues to have the same intensity.
It is uniformly bloody in all the three.
Absolutely. So that is the difference. And of course, it is xanthochromia, and this is frank blood. Okay. Then there are questions. Then there is that nicardipine, labetalol, and hydralazine are all known to have been used. But my question here is that you said it was an excellent presentation, Didi and
Sindhu.
I think both of you moderated exceedingly well, and Sindhu, I think, presented it's absolutely outstanding. I would give her the full marks. I think both of you together, you moderated so well, and Sindhu answered those questions and presented so well. Now here, my question to you is a practical point. But you said that if it is more than 180, you must bring it down to somewhere around 160, right? 160 to 180. How difficult or how easy it is to maintain that? What exactly do you do? What kind of a monitoring you would like to put in this so that it doesn't go below 160 nor it goes beyond 180?
So I think that's a very valid point, sir. I think first point is whether you will ever be able to convince our neurosurgical colleagues that such reduction is not necessary, because they are still steeped in the belief that if you have an aneurysmal subarachnoid hemorrhage, you'll have to bring the BP targets to very low levels. So that's what they really push us on. First is to convince them and show them the evidence that at least the European guidelines clearly states that don't reduce it. Obviously, as Dr. Sindhu had said, it has to be done with an invasive arterial line monitoring and titrable IV infusion. I would definitely try to keep it at 180 and not less, maybe about 160 at some points of time, and at any point of time it drops to below that. Shut off the shut off the IV labetalol. So some of these patients are also on IV nimodipine, and that can also cause blood pressure drop. And therefore, in these patients, I think it will be preferable that you switch off from an IV nimodipine to an oral nimodipine, because the efficacy of oral nimodipine is very well known. So, oral nimodipine in the dose that was mentioned, 60 milligram Q4 hourly, that would be the best way possible. So, two reasons. One is that the titrating dose of IV labetalol, you can shut it off. Second, if you are on IV nimodipine, in addition to it, so stop the IV nimodipine and switch to oral nimodipine, which is one way of preventing the overshoot of blood pressure below the estimated targets.
The rescue medication, I think IV labetalol is very, very predictable.
Yes, sir. It is.
Yeah.
It is very predictable.
Very predictable. It doesn't actually give you a shock or a jitter, and you can do that. My only thing is that when you actually monitor these patients, one has to be sitting by the side of the patient. I think you cannot afford to go out of this patient, and every blood pressure recording has got to make you conscious that you have to do something about it. I think it is not so easy to maintain a particular pressure or around that unless you are sitting there all the time. I think that has to be emphasized. Two eyes and one brain have got to be engaged all the time for maintaining this for at least the first 48 to 72 hours.
Yes, sir.
Something which normally you do not get to see in intensive care units.
Agreed, sir.
Okay. That is it. And then some more questions. Let me just find out. Most of these questions are in form of comments, actually. They have put in their experiences, very nice experiences. IV nimodipine, have you tried? And how good is it? Because I haven't tried IV nimodipine. We have used only the nimodipine QID doses, 60. Very well.
You can use it in intra-arterial forms, intra-arterial nimodipine at the target site.
Boiling ICU follow-up আছে জানি না তো চিরাঙা তো হয় না তাহলে আমাকে বিস্তারিত
Dr. Devaprasad, you would like to put?
No, I would use only oral nimodipine. But I also understand that there are neurosurgeons who prefer to use IV nimodipine. So I would try to convince them to use oral nimodipine for all the reasons that I said, that at least I don't have dangerous hypotension. And there was at least initial studies that seemed to suggest that IV nimodipine had a higher odds ratio of mortality of more than 1.3. Of course, that was not subsequently seen in other studies. So my personal preference is to use oral nimodipine. But however, if I'm unable to convince somebody and they insist on IV nimodipine, I allow it to have to be until the BP falls. If there is a tendency for the blood pressure to fall, I shut it off and insist only that oral nimodipine should be used. But I agree that oral nimodipine is a preferable route than the IV nimodipine.
Okay. There is another question. Triple H therapy has become double H now, and so hypervolumia is out. Now the onus lies on us to maintain a euvolumia. How do you ensure this, and what are the monitorings that you need to do for maintaining euvolumia? It's not so easy to maintain euvolumia. you either or in hypervolemic side, or sometimes you may also or in the hypovolemic side. So how do you monitor this? That's a question. It's a very valid question, I thought.
Yes, yes. I think the best way is to weigh the patients, but unfortunately, we don't have weighing scales in all the beds. We have only in few beds, and most often than not, it can't be done. That's the ideal way to do it. But the second best way is probably to have a strict charting of your input and output and see that they are in match and you are not in excess of more than 500 ml every day. So that is something that you can actually do it. But otherwise, as you said, a strict monitoring is not really possible. So, daily body weight, which is not feasible in the vast majority for practical concerns. But what can be done practically at the bedside is a strict monitoring, judicious monitoring of input output on a daily basis, and to ensure that you are not in significant positive balance at the end of every 24 hours.
If you have a little more retention, then you end
Yes.
up in giving a little bit of furosemide, and then that causes hypovolemia.
Sure.
That kind of
Yes,
a ding dong
I know.
battle goes on all
No,
the
no.
time.
Definitely, you shouldn't give any diuretics at this point
Yeah.
of time. I think it is okay to slightly keep them volume overloaded unless you have pressing indications like this patient is in difficult to ventilate situations because of a non-cardiogenic pulmonary edema with difficult to ventilate situations. Then it may be a different reason. Normally, I think you did see those issues of non-cardiogenic pulmonary edema more in the past, where we were focusing on a hypervolemic target as well, where we used to have a lot of fluids being given every hour. That is probably, and I think with that change of practice, with focus more towards just hydration and ensuring that the patient is euvolemic or slightly high in volume, I am seeing less of those complications of non-cardiogenic pulmonary edema as well. And therefore, as Dr. Banamber has rightly said, I think we should slightly keep these patients hydrated and not focused. If you have a situation where you think he is hypovolemic, please avoid giving Lasix, because otherwise there's a ding dong. You will probably drop your blood pressure and cause more problems than what you intended to really have.
Yeah, that's an excellent explanation, Didi. I think that is extremely important. Two things. One is the blood pressure management, one is the fluid management. I think both these things warrant that somebody knowledgeable should be all the time with the patient and shouldn't be looking after any other patient. To my mind, such an important patient, this condition, and a little erring here and there would actually end up in complication for sure. So I think that's the magnitude of the intention to treat such patients with total commitment. That is important to understand. Any other? I don't see. We talked
I
about.
think I think one question is, if no spasm, should we treat blood pressure above 160? I think we have answered it. If the patient, whether they have spasm or not, if the patient has been coiled and the blood pressure is more than 160, don't actually do anything to reduce it. It reduces itself in a matter of time. So the body is probably doing it with the reason. So don't really address it at this point of time. And another question is, do we need antiplatelets post coiling? I think post coiling routinely not needed, but nowadays I think they are also using flow diverters. And when they are using flow diverters, or when they have an inadvertent, what they think is probably a thrombus, then they want to add antiplatelets. But that's for whoever does the intervention to really say, because routinely it may not need it post coiling, but if they post coiling they see that they may have seen what is like a thrombus while they're doing the procedure, because then they may, but otherwise routinely it is not necessary. uh, but otherwise I can't. I think there's another question on what is the difference between vasospasm and cerebral ischemia. Vasospasm is actually vasospasm. Not all vasospasms need to lead to cerebral ischemia. But cerebral ischemia is when you actually have infarcts there on it. But otherwise, I think it more or less means the same, but except the intricacies. I think otherwise, I think there is one on salt waste clinical.
There is a question. Is it talking about Takasubo because of sympathetic surge, or is the question on Takasubo or anything else?
I think it's on Takasubu only. Yes,
Okay.
these patients do have increased sympathetic surge, and that's the reason why they have high blood pressure, and sometimes they may have a Takasubu type cardiomyopathy. That's becoming rarer in those situations. Then blood pressure, maintaining blood pressure at lower levels becomes a necessity, but otherwise not really.
Now, Takatsubo is a disastrous complication in
Yes.
such a situation. If it happens, I haven't seen a case in subarachnoid hemorrhage Takatsubo. In other cases, of course, we have seen quite a few, but not in subarachnoid hemorrhage. But it certainly is a very, very dangerous complication. You would always be handicapped to treat subarachnoid hemorrhage or Takatsubo, right? I think
Yes.
contradictory management.
Yes,
Okay.
yes, sir.
Any other
And there's one
point?
comment saying clinically salt wasting has low volume. Yes, the patient will be dehydrated, and the uric acid levels will be high in these patients because of dehydration.
I have a question. If the patient is on ventilator and pulmonary edema, usually now it is a dilemma, then we cannot diurese too much. So we would be giving sleep, and that will increase the ICP. So in that case, what to do?
Sorry, I'm not sure whether I heard the full thing. I think you just talked about a patient who's got an acute pulmonary edema and you can't diurese them in those situations. Can you just explain it louder, please?
Yes, sir. So if a patient is on ventilator because of pulmonary edema, and so there are two ways to treat, either to diurese them or give sleep. And both of them would be harmful for the patient. If you diurese too much, then it will cause vasospasm. If you will give feed, that will cause increase in ICP. So where we stand here and how to treat this one?
You'll do two things. You said one is diurese. What is the other thing? I couldn't hear that well.
Feed.
Diuresis?
Feed. Positive and expiratory pressure.
Okay, you're talking about PEEP. Fine. See, in these issues, I think there was this talk about a multi-modality monitoring on these tops. Yes, that's something that is done. But let's say that in practicality, in most of our issues, we are not using them, and therefore you are talking about a situation where you would have a patient who is volume overloaded, difficult to ventilate. In them, how would you really ensure that this particular patient has enough oxygen? That's the question, right? So I would definitely not diurese these patients at this point of time. I would probably just ensure that they have even balance at this point of time, and maybe and I don't see a hesitation in going up on PEEP in these patients, especially if they do not have raised sign of raised signs of ICP in these particular patients. Especially if they don't have hydrocephalus, then I don't see this. There's a reason. Of course, if you are too much concerned about raised ICP in these settings, it may not be a bad idea in these patients to place an ICP monitor and ensure that your PEEP doesn't raise it. I think the contribution of PEEP to ICP is a concern, but I think it is overemphasized. It is overemphasized. So I think the best way is to increase your PEEP as appropriate, and also monitor your ICPs just to make sure that with your increasing PEEP, the ICP does not rise. If that's not happening, I think you could reasonably reach a point of PEEP. And if this is fluid in a matter of time with attention to the fluid balance, it is most likely to settle. However, if this is Takasubu's cardiomyopathy, then you would have a different point. It's going to be very, very difficult in these situations. And in these patients, you'll probably have to use IABP in these patients to actually really manage these patients, because only then these particular patients would have a relief of the hypoxemia. So to just summarize, the hypoxemia and difficult to ventilate has to be understood. If it is because of a fluid overload status, I would say that it is best not to diurese these patients. Just keep them an even balance and appropriately use the PEEP. If you're concerned about PEEP rising the ICP, I would say that do increase your PEEP under ICP monitoring. On the other hand, if this increase in your oxygen requirements is because of a cardiogenic cause like a tachycephalic cardiomyopathy, in these patients you would probably have to offload, and these patients may best be managed with an IABP. And remember that IABP has been used both to treat tachycephalic cardiomyopathy and also to treat patients with vasospasm. So that could be a win-win in situations. But I'm just saying that if this is tachycephalic cardiomyopathy causing hypoxemia because of cardiogenic, then that would be a possibility. I hope that answers your question.
Yes.
Didi, I need to add one point here.
Yes, sir. Yes, sir. Please, sir.
If the end expiratory pressure you have to increase to a higher level, say beyond 10
Yes, sir.
per C, I don't really need to do that so often. Sometimes we do.
Yes,
If
sir.
that happens, then in that case, if you think that it is an optimum peak, looking at the compliance, at some point the compliance starts reducing. There you don't increase speed further, right? But if the
Yes.
compliance is still having some scope to become better, you continue to do that. This particular higher P will not be transmitted to decrease the increase the venous pressure, so that the cerebral perfusion pressure is decreased. It doesn't actually do. If it is
Definitely.
required for a situation like this, please do that. But you have to again be on your guard that the sooner that you can reduce it, the better for the patient. Be very vigilant. But if it is required to increase oxygenations, you must do it, because that's very important. So therefore, it has to be an optimum PEEP. You must always look at the compliance and look at the PEEP level and keep adjusting that to get the best compliance. It will not be transmitted to the venous side so much.
Okay, sir. So, when are we going to start vasopressor? If the map is below 80, should we start vasopressor, even though there is no vasospasm, before coiling and even after coiling? Before coiling, we were using around map of 80 is fine, but if it is below, we are not inclined to. We just give either fluid or we will not give any vasopressor. Even after coiling, also, we are reluctant to start vasopressor. So when is the point that we should start vasopressor?
So I think in the interest of time, we can conclude the session. It was indeed a very good session and well presented by Dr. Sindhu. Thank you, Devaprasad, for this.
Thank you, Dr.
Thank you,
Krishnan.
sir.
Thank
And
you.
I also thank
Sindhu and Didi have been outstanding.
Thank you,
Sindhu
sir.
and Didi have been outstanding. This is my impression, and I think it's terrific session this was between both of you.
Yes.
Thank you, sir.
Indeed.
Thank you, sir. Thank you, Dr. Akhilesh. Thank you, Farz. It has been
Thank you,
wonderful. I think.
Dedeepiya.
Thank you.
Thank you, Banamber sir.
Okay.
Very
Okay.
nice.
Thank
Thank
you,
you
sir.
very much.